Finally, we are joined by Dr. Ola Landgren, who is Chief of Myeloma Service at Memorial Sloan Kettering Cancer Center. Hi, Dr. Landgren. We're so happy to have you here today.
Thank you so much for having me.
Great. So, the MAIA study, which is looking at frontline daratumumab with lenalidomide and dexamethasone in patients who are ineligible for transplant, is an eagerly anticipated abstract this weekend. So, this is a late breaker abstract, but what can you tell us about the study design and why this trial is important?
The presentation will take place here on Tuesday morning, so we are not allowed to give the details of it, but we know that there is a highly significant superiority for the three-drug combination. So daratumumab in combination with lenalidomide dexamethasone is highly significantly better for progression-free survival compared to the Revlimid dexamethasone. I think it's going to be a very exciting study, and I actually think the study potentially could introduce a new standard of care for patients that present with a new diagnosis of multiple myeloma. For a long time, the VOD regimen with bortezomib with lenalidomide dexamethasone has been the favorite in many centers. Now we have another option. We have also the KOD regimen, the carfilzomib lenalidomide dexamethasone. Again, we have a new option here. I think that could be uptake for many patients in different places with this new regimen.
Yeah, that's a great point. Now, part 2 of the phase 3 STORM study is looking at Selinexor with low-dose dexamethasone in penta-refractory multiple myeloma. So could you discuss Selinexor and how these findings are impacting the patient population?
Selinexor is a drug of a unique class. It's a protein transport inhibitor that blocks the influx, outflux of certain proteins in the nucleus of the tumor cells. So the cells basically get clogged with bad proteins in the nucleus that they don't like, so that's why they die. The study here showed that the Selinexor in combination with low-dose steroid, dexamethasone, results in a response in patients that are heavily pretreated, patients who have failed all the other FDA-approved combinations. You still see about a quarter of the patients are responding. The duration of the response in this quite heavily pretreated population is about 4 months. So that's the duration of the response. Also, there are toxicities that have been seen with Selinexor. It's been reported at other meetings as well. It involves the gastrointestinal toxicities with diarrhea. There is nausea involved. Patients have fatigue and asthenia. So I think there is a little bit more work, I think, to be done. And there is actually ongoing work that we anticipate to see here in a couple of months at coming meetings and in coming reports in combination with other drugs. Velcade dexamethasone with Selinexor, pomalidomide dexamethasone with Selinexor, Revlimid dexamethasone with Selinexor, daratumumab with Selinexor. So we have the whole alphabet soup here with Selinexor, and peculiarly the toxicities I was mentioning seem to be actually slightly lower when you have these other drugs in combination. So I think the story is to be continued.
Very interesting. Okay. Now, there's the quadruplet regimen of daratumumab, bortezomib, lenalidomide, and dexamethasone, which is being explored in the Griffin study. So what's important to note about this trial?
So 3 drugs, 4 drugs, how many drugs shall you give? So the standard of care for newly diagnosed patients with myeloma is 3 drugs. I talked about the VOD regimen with bortezomib, lenalidomide, dexamethasone being probably the most commonly used in private practice. Then I also talked about the KOD regimen with carfilzomib, lenalidomide, dexamethasone. There is more uptake in the academic centers. We use this as our default. I think that's a more powerful regimen than the VOD regimen. I actually give a talk here tomorrow from the COMPASS study, where we have done a nested case control study within the COMPASS study showing that there is superiority for the KOD regimen. That's actually quite profound for event-free survival. So what about these 4 drugs? So you mentioned the VOD with daratumumab. So the Griffin study will be presented here at a meeting by Peter Voorhus, showing that if you add daratumumab, you also have better, deeper responses and you have better progression-free survival. I think it's important to also emphasize that it's very early, so the Griffin study has not yet kind of read out its primary endpoint, so they enrolled all the patients, but the data is very early. We also have a presentation ourselves here where we use the KOD regimen with daratumumab. So I give a presentation here today at the poster session where I show up to 80% MRD negativity with this KOD regimen with daratumumab, and this is without transplant. So this is very, very strong. Early on, small numbers, We need to have more patients followed longer, but it looks very promising. I think 4 drugs is going to become the new standard of care for patients who are in good shape, who are fit. And then the question is, do you need to transplant all of them? I'm not sure that needs to happen, but that's certainly controversial, so to be continued.
So I'm really glad that you mentioned this other presentation that you're a part of. Would you like to expand a little bit more on it?
Yeah, so from this poster presentation that I have here today, we show the 4-drug combination with daratumumab with the KOD, or carfilzomib, lenalidomide, dexamethasone. I mentioned the high rates of MRD negativity, 60 to 80% in that range, which is quite strong data. So beyond just like the traditional workup and including the bone marrow MRD, we also have now started showing data that we have worked on for a while, blood-based MRD testing. We have worked for about 10 years in the laboratory trying to figure out how can we use blood-based testing to be the new way of doing MRD, because much better for patients. You don't have to do biopsies. You can actually do it much more often. You could technically do it every time you do blood draw. So I think circulating DNA is not going to be the path forward, because there is too little tumor DNA to be used reliably to rule out MRD in the blood. You need so much blood, so it's just not practical. I also think the circulating tumor cells in the blood are too few to reliably be used, so there will be a lot of false negative. So instead what we have done, and that's what we present here, is that we use mass spec-based technology. So we are looking for very, very low levels of proteins that have been made by very small number of cells. So we now have technologies that are probably 1,000 times more sensitive than anything that we used to have before. They are pretty much correlated in terms of sensitivity, it seems, to about the level of what flow cytometry can do in the bone marrow.
Okay.
So that's very interesting. So what we are trying to do now is to see how we can look at the slopes of these proteins and longitudinally follow and see if this potentially could either replace or complement the monitoring for patients treated with these new modern therapies. So I'm very excited about that.
Yes, it does. It sounds very exciting.
Yeah.
Great. Now, moving on to ixazomib. So maintenance treatment with this agent is being addressed in the Tourmaline MM3 trial in newly diagnosed patients after transplant. So what are your thoughts on this study and the findings?
Ixazomib, that's one of the new drugs. We have so many new drugs here. So ixazomib is FDA approved for the indication of recurrent myeloma in combination with Revlimid dexamethasone. People have wondered, could this be a new maintenance drug? So the trial you're referring to is a randomized study that reads out. So the control arm is placebo. So you compare the ixazomib to no drug, and then they show in this presentation that there is a superiority. It was presented by Thanos Dimopoulos from Greece. He also showed that the duration, the benefits with the addition of ixazomib is about 4 months. So I think if you look at the duration of Revlimid compared to nothing, it's less with ixazomib. So I think the clinical message here is that probably ixazomib could not replace Revlimid. But I also think it's important to emphasize that there are many patients who go on Revlimid maintenance who cannot really tolerate it.
Right.
They can have gastrointestinal symptoms, diarrhea. Many patients can develop fatigue. They cannot really function, and there could be other issues as well. So I think it's just another option, and I think that's how the field seems to keep on evolving. There's just another option, another option, another option. So looking for these phase 3 trials that show survival benefits and head-to-head, that seems to not really be the direction where the field is going. It's just going to be a lot of new drugs approved, and I think the doctors have to use their judgment and talk to the patients about all these different options, and different doctors, different patients will have different opinions. So it's becoming more complicated. That's kind of the side effect of all the advances we have seen with all these new drugs.
And I'm really glad that you ended with that, because I really want to get in your head and talk about, where do you see the myeloma landscape going a year from now? What does it look like to you?
So it's obviously impossible to know, so I will have to kind of put my guessing hat on, so do some kind of a best guesstimate here. I do think that the antibodies moving up front is definitely going to change the game plan. I think the uptake from Maya can be quite big. So the Maya study with daratumumab, with lenalidomide, dexamethasone, I think it's a great option for many patients. You don't have the neuropathy that you see with Velcade. You can deepen the responses. It's very well tolerated. that also introduces a new maintenance along the lines of what we discussed before with the Asilon trial, when they stopped the Velcade melphalan after 9 cycles and continued just with daratumumab. So daratumumab could also become a new maintenance actually. So here we have a third option.
Right.
Although that was not really how it was developed for the purpose of the trial, but it kind of ended up being like that. So I think the antibodies will move up early on, and that could also lead them into the extension of this. And then we talked about the Griffin study, and we talked about the Sloan Kettering study with daratumumab in combination with KRD. So I think the field will slowly migrate into a direction where you could have antibodies up front, maybe with lenalidomide dexamethasone, or you could have the 4-drug combinations with amazing MOD results that really is going to continue to deepen and prolong the duration. And then I think the MOD testing will have a very important role, because I think that could also lead to MOD-driven decisions. So could you maybe collect stem cells and not transplant patients? That's what we already are doing at Sloan Kettering. Could you use that if patients, God forbid, were to have a recurrence early on with conversion back to MOD positivity? Could that in the future trigger retreatment? That's not in the guidelines, so don't try this at home yet. So I think those are things that gradually are going to come into the new game plan. So a lot of change and many new drugs are coming. We did not talk about the bispecific BCMA antibodies. They're spectacular. We didn't talk about the CAR T cells, also amazing results. And there are a lot of other small molecules you have beyond the venetoclax. You have also MCL1 inhibitors. Could you have a BCL2 inhibitor with an MCL1 inhibitor? From a rational standpoint in the lab, that makes very good sense, and there is preclinical data showing that is really amazing. So where all these things are going to go, and where do they fit, and so many questions we don't know the answer to.
But there's a lot going on, so it sounds very exciting.
Very much going on.
Great. Well, Dr. Landgren, thank you so much for being here today. We had a great time talking with you.
Thank you for having me.
Thanks.